Good evening, everyone. My name is Kat Cook, and on behalf of the Orthopedic Institute at St. Elizabeth's Healthcare, I'd like to welcome you to this educational event. The Orthopedic Institute is a partnership between St. Elizabeth's Healthcare, OrthoCincy Orthopaedics, and Sports Medicine, and St. Elizabeth Physicians. The goal of the Orthopedic Institute is to improve the care and delivery of multiskeletal medicine by focusing on quality outcomes, efficiency, and patient satisfaction. I'm excited to moderate this webinar on ACL injury prevention. Before we start, let's take a moment to ensure that everyone is ready and familiar with the webinar platform, which is located on the bottom of your screen. Questions may be submitted through the webinar panel using the Q&A bubble located on the control panel. If it's not already open, just move your cursor to the bottom of the screen for the control panel to appear, and then click the Q&A option. A screen will appear to prompt you to submit your questions. Brad McNutt and I will be helping collect your questions for our panelists to answer. This webinar is also being recorded and will be posted at later reference. Now let's get started. I'm pleased to introduce orthopedic surgeon, Dr. Adam Metzler from OrthoCincy Orthopaedics and Sports Medicine. Dr. Metzler is considered one of the area's leading ACL surgeons. He serves as a consultant surgeon for the Orthopedic Association of America and teaches surgeons around the world how to perform ACL and complex knee ligament surgeries. Dr. Metzler is joined by physical therapist and certified athletic trainer, Kathy Boehmer from St. Elizabeth. Kathy has been treating sports injuries for high school, college, and professional athletes for the past 24 years. Thank you both for being here. Dr. Metzler, you may now begin your presentation.
Well, thanks for having me, everyone. It's a pleasure to be speaking tonight. Hope we got a good crowd. So we're going to talk about ACL injuries and the injury prevention program. And we're really proud of a program we're going to be releasing here. And so the big impetus of this discussion today is really to bring in some experts on ACL injuries, and the hope and prevention, our hope and idea is that we can hopefully prevent future injuries for our athletes and prevent the need for potentially some of those athletes for having an ACL injury. In regards to the injury prevention program, which Kathy's going to talk about, I think it's really important to understand kind of how we got to that point here at OrthoCincy and St. Elizabeth, and talk a little bit about what an ACL is, its importance, and the value of our drive to create an injury prevention program. So we're going to go ahead and get started here. So we talked a little bit about the Orthopedic Institute, and Kat already discussed that, but we're very proud of our relationship that we have between OrthoCincy and St. Elizabeth, and we really value our collaborative efforts. Our focus is providing excellent musculoskeletal care, focusing on quality outcomes, efficiency, and patient satisfaction. And we hope with measures like this that we're continuing to strive to be the best orthopedic institute in the region. We'll go ahead with our next slide. So we have a lot of athletic partnerships. We have over 37 local partners. Our job is to work very closely between the St. Elizabeth healthcare providers, our athletic trainers, and the OrthoCincy physicians to take care of these 37 schools. Just a few of these are listed there, but we take care of Northern Kentucky University, Thomas More, and that number continues to grow. And we're very proud of our relationships. Most importantly, we're very proud to take care of the student athletes. So let's go into some numbers here. Let's talk a little bit about get into the nitty gritty. So the anterior cruciate ligament, also known as the ACL, it's one of the most common injuries seen by an orthopedic surgeon. And it's probably the most common complete ligament injury in the knee. There are approximately 250,000 ACL reconstructions performed each year in the US. 50% of those are in the 15 to 25 year old age group. 75% of those injuries are non-contact. What that means is no one physically makes contact, so it doesn't mean, most people assume someone took a hit from football or from hockey or a slide tackle during soccer, but a lot of times most of those are just a simple foot plant, they turn a pivot, and their ACL unfortunately gets injured. As many of us know, The female athletes are anywhere from 5 to 7 times more likely to experience a serious knee injury or an ACL injury specifically than male athletes. And for example, high school female athletes have a 1 in 100 chance of tearing their ACL. So that's pretty significant. It's even scary to think that female college athletes have a 1 in 10 chance of tearing their ACL during their collegiate career. And so, again, part of our impetus to try to create an injury prevention program is really the next sentence, is that patients who have a primary ACL are twice as likely to tear their other knee and a significant higher risk of osteoarthritis in the future. The typical sports related that most people realize is soccer, volleyball, football, basketball, hockey. Those are the highest rate of ACL injuries, but they can certainly happen in anything, in any sport. So huge emphasis. Why the emphasis on preventing ACL injuries? Well, number one, who wants to have surgery? We want to prevent the need for surgery, prevent those risks that inherently anyone can have when they undergo surgery. Significant athlete psychological distress of missing sports. We saw that with COVID. What better example? Significant higher rate of clinical depression. And so it's nice to see the kids back playing together in a safe manner, but we can prevent that. That's another great point, the psychological component. Most athletes are going to miss 6 to 12 months away from the sport with an ACL injury. That's if they do what they're supposed to do and everything goes well. Athletes with ACL injuries, they're 4 times more likely to develop a painful knee with arthritis within 10 years of the injury relative to a non-injured athlete. And to me, this is really the key point of the whole conversation today, is if we can prevent someone 30, 40 years down the road from not having to have this injury and not developing early arthritis, we can save them and those good quality of life years that we hope they would have on their knee when they're 50, 60, wanting to hike Red River Gorge, those kind of things, play with their grandkids. If they can't do those things, certainly it's going to, something that happened a long time ago has a significant impact on their life later. So it's 7 times more likely to eventually need a knee replacement and at a much younger age than those who haven't been injured. So again, for me, those 2 points are critical. We always think about the immediate future. The athletes think about the immediate future. Certainly that's always important to us too, but those last 2 points are really valuable for us. So just basic terms, what does a healthy ACL do? Well, an ACL helps prevent excessive sliding of the tibia, the shin bone forward on the femur. It helps to prevent rotational instability. So it helps provide stability of the knee joint. So why is the ACL particularly susceptible to this injury? Well, it's really just a very unique structure. It's a pretty small piece of tissue. It has a really big role. And we're not exactly sure. There's a lot that plays into it, but it has to be a combination of a lot of things. The anatomy of the hips and knees, lack of dynamic muscle support that really allows us to have this increase in ACL injuries. And there's certainly many other variables that play into this. And we'll talk a little bit more about that in a couple slides. So the slides now, excuse me. Why are females at such high risk of ACL injuries? So there's anatomic differences, there's biomechanical differences, there's hormonal influences, and there's neuromuscular differences. So all these are kind of complicated, and there's no way in a webinar we can go over this. And there's still a lot of theories and controversy behind this, but we do know that most females are 5 to 7 times higher, as we said earlier, for their ACL injury. These are some of the sub-factors that relate to that injury. And again, a lot of these are controversial in and of themselves, but they do play a vital role in the ACL female injury. Common causes of ACL injury. Again, we already talked about that. Essentially, the number one reason is indirect or non-contact, such as pivoting away from a defender during a soccer game or jumping to shoot a basket and landing with the knee. We call it valgus alignment. Kind of that L-shaped when they come down in a knock-knee position. And then there's the direct impact or contact against the knee, such as a helmet to the knee during a football game. So what are the symptoms of an ACL? Well, an ACL injury is typically, you're going to feel some type of pop or a feeling of a pop and a feeling of pain often early on. You can see these on TV all the time now with social media and streaming. Everything's pretty easy to see. An athlete has a non-contact injury, they go down, hold their knee. I would say 50% of those are some type of ACL injury. They often will swell because there's little blood vessels inside the ACL and they'll bleed inside the joint. And at first it's pretty difficult to walk, and the knee can have a sensation of pain or tenderness and instability. After a few days, the swelling and pain may dissipate, but the instability is what always persists. So if you see an athlete or a patient 2 or 3 months after an ACL injury, they typically don't hurt. They typically don't have swelling, but they will almost always be unstable. They don't trust their knee for basic things. Even turning a corner in their house can cause their knee to buckle underneath them. So such a small little piece of tissue in the center of the knee does a really important job, and it has a very important role. So I was a torn ACL diagnosed. It's mostly diagnosed by physical exam. It's pretty straightforward. A test we do is called a Lockman's test. It's 95% accurate in detecting an ACL injury. However, modern day medicine, we have something called an MRI, and the MRI does help confirm the diagnosis. A lot of times there's other associated injuries such as meniscal tears or cartilage injuries. And so it's really important to have an MRI to go in, kind of an idea to make sure you have a full picture of what's going on, because an ACL injury in most patients is a surgical problem. So before we go in there, we want to make sure we have all the pieces of the puzzle so we know how to handle that situation. As each knee is unique and each surgery is unique, even though our goal is the same thing, we want to make sure we have our plan very clear. So an MRI is very important for us, not only to confirm an ACL injury, but also to evaluate other structures inside the knee. So if someone thinks they tore their ACL, a lot of times it's fairly straightforward from an athlete standpoint, particularly with the schools that we take care of. And a lot of times, unfortunately, a trainer has a pretty good idea. They are often brought into our office very quickly, either through our urgent care clinic or into our office very, very soon. I would say within a 12 to 24-hour period, most athletes can get into our office unless it's a Sunday, and then they can usually see us Monday morning. But in the immediate term, we want to get swelling control. We want to get icing. You go on some crutches, maybe even a brace if you have that. But sometimes patients don't have as much of a understanding of it. So if they're at the local trampoline park and they twisted their knee and it stays swollen. Any swollen knee from a traumatic injury, in my opinion, should be an injury that should be evaluated by a musculoskeletal specialist. And so, knee swelling is the number one thing I tell all the residents that work with me. If someone's swollen, they need to be seen. That can be an ACL tear, a meniscal tear, cartilage injury, a patella dislocation. Those things need to be evaluated. If you live with an ACL tear for a prolonged period of time, your risk of tearing your meniscus is significantly higher. And when you tear your meniscus, we know that it significantly increases your risk of osteoarthritis. So again, we just talked a little about this, but ACL surgery is recommended to stabilize your knee. We want to protect your knee. We want to allow you to have a stable, functional knee so you can trust your knee, so you feel comfortable doing the things you love to do, whether it's yard work or sports. I mean, it's very hard to even cut your grass on a hillside with an unstable knee. From an athlete standpoint, obviously it's a little different. Our goals are much larger. We want them to get back to higher level activities. But I mean, ACL surgery is recommended for most people who want to be active. And so if you want to be an active lifestyle with cutting and pivoting, it's going to be recommended. Again, we want to reduce the rate of meniscal injuries, reduce your rate of osteoarthritis. And so evidence does support early ACL reconstruction in young patients to reduce the rate of meniscal tears. That's very important. So just to kind of summarize all this, we talked about what an ACL is and how you get an ACL injury and how we diagnose this, and briefly talk about how we treat it. We reconstruct your ACL. But again, the impetus of this whole discussion here is we want to talk about is there a way we can prevent this? And the science really supports that. And so ACL prevention programs that include specific dynamic exercise, they can reduce your risk of injury. And most recently, it was what we call a meta-analysis, which is a large, broad study. It looks at lots of studies. And this one was recently published in May of 2020. And it looked at a cluster of really good injury prevention programs. And essentially, they concluded that, and I have it summarized here, but ACL IPPs, which stands for Injury Prevention Programs, had a significant protective effect and reduced ACL injury rates by 53%. And so long before this was released, we had a vision and a goal at the Orthopedic Institute to come up with a well thought out, well done injury prevention program. And we're about to release that program. But this is the reason why. If we can reduce our rate even 25%. If we can get anywhere near that, we would be ecstatic for these young athletes and family members not to have to undergo an ACL surgery. And so I'm going to digress here a little bit. I'm going to let Kathy talk about the good stuff, which is what we're here for tonight. And she's got some great slides and some great stuff to share with us. Kathy, you're going to unmute.
Thank you. I was talking to myself, obviously, without the microphone on. I'm Kathy Boehmer. I'm a physical therapist and certified athletic trainer, board certified in sports physical therapy, working at St. Elizabeth Healthcare. Friday was my 25-year anniversary. So this has been a passion of mine for most of my career. So I'm happy to be presenting on this topic tonight with Dr. Metzler. So what is an ACL injury prevention program? It is often referred to an IPP. It works to improve how we move in order to prevent injury. The focus of these kind of programs are on the technique and the skill. The training can take place year-round. A lot of teams will do preseason training that can be 6 to 12 weeks long, and then you can do a shorter duration in-season maintenance program. So what does that include? When should you start? Training is most beneficial if athletes begin at a younger age, so like the 11 to 12-year-old range before they start to go through puberty. Younger athletes, the research shows that they have greater improvement in body mechanics than their teenage counterparts, and that program can be continued yearly until they're skeletally mature, which is about age 18. So the program that we're putting together at St. Elizabeth with the Orthopedic Institute and OrthoCincy is, it contains 5 components. It is a dynamic functional warm-up, neuromuscular balance, jump training, landing specialization, plyometrics, and strengthening. So the dynamic functional warm-up is a series of movement that involves dynamic activities or sport-specific activities that take your body through a big range of motion and kind of focuses on what you're going to be doing in the sport that you're participating in. And if this is done properly, it may actually help decrease your risk of injury. So if we can get this video to work, this is one of our athletes from Dixie High School, and she's going through a functional warm-up. So it's just a series of high knee skipping. She's going to do some butt kicks, anything that will kind of get your muscles working versus the old static stretching. She's going to do a lateral slide. And so we're trying to work on the quality of her movement, make sure she's in good hips flex, knees flex position, keeping her abdominals tight, her head up, looking up. So any of those kind of things, you can do high knee kicks, you can do some sprint workouts, any of that kind of thing, just to get your body warmed up. There is a new program that I'm trying to put together for Notre Dame High School right now. I just went out and videotaped their basketball team yesterday just to say, okay, what are you guys doing for a functional warm-up? Let me add some of these research criteria into your program and see if we can decrease your risk of injury just through some of the dynamic warm-up that they're going to do. You can go to the next slide, Kat. So the next phase is the neuromuscular or balance portion. So poor balance and control have been linked to an increase in lower extremity injuries. These exercises involve multiple joints and multiple muscle groups, and they're usually in a weight-bearing position. These exercises actually challenge your nervous system, and they challenge your body to work on kind of maintaining your balance through different movements and activities. And the emphasis on these exercises are the quality and efficiency of the movement, as well as the alignment of the knee and lower limb joints. So I'm all about position and perfect technique. I'm always about the quality of a movement over the quantity, and whether it's 1 rep versus 100 reps, I need the athlete to be in the right position at the right time and kind of train them in that position always. So some neuromuscular control exercises. I kind of went through like a beginner, intermediate, and advanced. So Lacey here, she's just doing a single leg balance exercise. So I have a 9-year-old son, and whenever people ask me what their kids can work on, I said, have them stand on one leg when they're brushing their teeth. Hips even, back tall, tighten their belly button toward their spine. a lot of kids, especially the younger ages, they can't even balance on one leg. And then I had a cheerleader in earlier today. I'm like, let me see you balance on one leg. And just the fact that she couldn't even hold her hips in alignment sets her up for more injury. So I always start with a good single leg balance. And then once they get that down, they can do a clock where they kind of point their opposite leg into the direction of the numbers on the clock. Or they might stand and balance. If you're working with a team, each athlete could stand on one leg, they could throw a ball to each other or bounce a ball to each other, anything just to get your nervous system activated. So some intermediate exercises for this section would be like single leg balance on an unstable surface. So if you can see Lacey under her right foot, she has a pool noodle. So we just cut a pool noodle in half, and I said, okay, stand on that. Everybody can get one of those at the dollar store. Cut a pool noodle in half. I'll tell kids if their parents let them, they can stand on their bed and balance, just so they don't get hurt. Then they can do the clock on the unstable surface, and then I'll have them transition to a single leg squat, working on proper technique. So then the next phase is the advanced phase. This is, you could do a single leg balance on an unstable surface with the ball toss, single leg squat on the unstable surface. And then this is one of my favorite exercises. It's a single leg squat. We call it the running man. So that she's kind of coming down, keeping her back in alignment, putting her knee and hips in the right alignment. And it really works on the control of your hip and pelvis. So she's going to lower, and then I'll have her bring her left leg up in the air when she comes up, and just kind of repeat that until she fatigues. So the next section is the jump training or landing stabilization. So ACL, the research shows that ACL non-contact injuries frequently occur during deceleration, landing, or while training to execute a lateral directional change. And Dr. Metzler had said that about like changing positions in soccer or basketball. And it's that poor landing technique that puts enough force through the ACL, or could put enough force to cause it to tear. So the focus of this section is the proper jumping and landing mechanics. In the next slide, I actually put a picture of one of my athletes from Notre Dame. It's quite a few years old now, but all this athlete had to do was to dribble the ball for 0.2 seconds. And in 0.2 seconds, go ahead to the next slide, she actually tore her ACL pivoting. So you can see her left knee. All she was trying to do was dribble the ball to run the clock out for 0.2 seconds, and just made a directional change and tore pretty much everything in her knee in that moment. So we want to really focus on the jumping and landing stabilization. So what's the optimal position? It's kneecaps facing forward in line with your hips and your feet. Your hips and knees are flexed to allow your muscles to absorb the forces of jumping and landing. And my cue for them is always to land softly. So if you're going to work with your athletes, they have to start with the right position before they continue. And I think I see some of our coaches and gym teachers on this webinar, make sure that they're in the right alignment. It's harder when there's more than 5 athletes to pay attention to technique, but it's better for you to pay attention to their technique while they're with you, because when they're not with you, they're probably not jumping correctly if they're not having someone correct them when you're with them. So some beginning exercises is a double leg box drop, and then you can progress to a single leg box drop, and then going down on 2 legs, landing, and then hopping to one side. Some intermediate hops would be, or jumps landing would be a double leg drop jump, and then a single leg side to side hop. So you're kind of landing on that leg and then moving to one side to try to challenge you. She's laughing because I was telling her she had to work on her technique. The double leg hop to a single leg, so you land on both legs and then you jump forward, landing on one leg, maintaining that good alignment and position. Remember to keep the knee back behind the toes, knee and hips in line, and back tall. And then the more advanced phases would be the speed skater. Is there a video here? So she's gonna land, and I tell my athletes to hold it. So to land, like to stick the landing. And she has to be able to maintain that position. And if you look at her shoulder, her hip, her knee, and her foot are pretty much in that alignment on that right side. If they start to go into that, it's called the valgus position, where the knee would actually collapse inward, I stop it right away and I make them work on that. And again, kind of picking on my cheerleader from a couple hours ago, she was there for an anterolateral ankle sprain, but her technique on this was so bad. I told her mom if she didn't work on it, she was probably going to be back for some sort of near ACL or patellar tendon injury, because her knee was completely folding in. I should have taken video of her because she would have been a great one to show what not to do. So that's one of my favorites. And then the next phase is a plyometric exercise, which are powerful exercises used to increase speed, endurance, and strength. And these exercises, you want to exert the most force possible. So you're going to jump high, jump far in a short period of time. This really challenges your nervous system to work together with your muscles and your bones to, really bring that force and build strength. So some exercises, beginners, are just some toe taps, alternating toe taps, tuck jumps, broad jumps. Those are all things that are basic. There are other ones that you can do, but these are kind of the fundamental ones that we start with and then progress from there. So the intermediate, so this is a repeated tuck jump. So I had her doing like 10 tuck jumps in a row. And this is also an indicator for how well someone's jumping. You can videotape this and watch as their technique, they start to lose their technique over time. So I'll break it down for them on a huddle video and show them their alignment and show them what to work on. And then when I get them back in a couple weeks, I'll take that video again and then compare it to hopefully show some improvement. Other activities are jumping lunges and lateral broad jumps, anything where you're jumping high, jumping far. And then the advanced phase would be a single leg repeated vertical hop. She's gonna jump straight up in the air as high as she can go. Then, is that one a video of their cat? So Lacey's jumps are not very high. I would like her jumping higher, but that's what I got that day. But so if you want your athlete on this one to be jumping as high as they can go and as far out as they can go. And then some other exercises are forward bound and a single leg zigzag bound. So you want those athletes to jump as high as they can. And then the final section of our program would be a strengthening program, and exercises work muscles as they move against resistance. You can do anything from body weight, weight machines, free weights, barbells, elastic bands, and as people found out through COVID, you can use water bottles or different things around the house. I recommend that the younger athletes do everything body weight. Actually, if it were up to me, all my high school athletes would start body weight, because I am not joking, 9 out of 10 athletes I get in the clinic can't do a push-up correctly, can't do a plank correctly. And I've had Highlands football players, Notre Dame soccer players, it doesn't matter how high level these kids are, that have just terrible body weight mechanics. So I make them work on that first before I'll even let them advance to something with resistance. And then obviously the benefits of strength training are reducing the load on your knee during athletic activity, increasing your endurance, metabolism, improving your posture, and hopefully decreasing your risk of injury. So some strengthening exercises that are kind of the core to this program are going to be your squats, knees behind your toes, butt back, head up, heel raises, and then kind of advancing as they go along to some single leg heel raises. And then you go to forward lunges, lateral lunges, making sure that they can maintain that upright posture, keeping their abdominals set and stable. And then you can, as they get stronger, you can advance to like a walking lunge or walking lateral lunge. You can add some free weights to that. You can add kettlebells or dumbbells overhead, anything to work on increasing the strength. And then some other additional exercises are my favorites: the side plank, push-up, modified side plank. Lacey's push-up's not my favorite, but she didn't know she was getting set up to do all of those that day for me. But any progression of the planks, side planks, I try to work, I call my core 4, like a side plank, a push-up, a bridge, anything that works the body in all directions. But those are the basics that you need for any kind of strengthening program. So anything you can work on and with good technique, good strength will help decrease your risk of injuries.
So this is now our Q&A portion of the webinar. If you have any questions, please put them in the Q&A bubble when you toggle over your control panel. And we are happy to have Dr. Metzler and Kathy answer any questions that you may have. To kind of get us started, we do have a few questions, just general questions that we feel the public often answer. And this goes to Dr. Metzler, and then it'll also go to Kathy. Dr. Metzler, how long does it take to recover from an ACL surgery? And then Kathy, if you can answer how quickly after you start physical therapy.
To answer the first question, the science is pretty clear on return to play. I will tell you that the average return to play for an NFL athlete is 10.5 months. So that gives you a perspective. This is someone at that level who's a well-oiled machine, obviously genetically gifted in life to be at the position they are, with significant funds to pay for a full-time athletic trainer and physical therapy team to work with them. So 10.5 months. The science says 9 months is probably the earliest we should let someone return to play based on the ACL maturity. So when we put tissue inside the center of the knee, it takes time to biologically mature. Now you can get away if you're lucky with that return to play earlier, but you are gambling more because your injury and re-tear rate does go up 50% if you let someone return before the 9-month period. So that 6 to 9 month window where they used to let a lot of athletes go back, and I have myself, and do if the patient's appropriately conditioned and has done the things they need to do, does put them at increased risk. So we shoot for a 9 to 12 month window. I know that's a long answer for a short question, but the reality is there's more to the story than just a number. You certainly will give a number to your patients, but it's up to them to do their part. If they don't do what they need to do, then ultimately it may be longer. If someone gets stiff after surgery, it could be 12 months, 15 months. I would say most of our athletes are returning in that 9 to 12 month window. They need to psychologically feel comfortable too, and it can take well over a year for an athlete to psychologically even want to risk re-injury. And so I'm going to step back for a second and let Kathy answer the second part of that question.
Okay, could you repeat the second part for me?
Yeah, how long after you get your ACL surgery do you typically suggest starting physical therapy, and kind of where does that start in that process?
We usually start about 3 to 5 days afterwards. Most people don't feel physically well enough to come in the day after, but by day 3, they're usually ready. Sometimes we'll wait through the weekend depending on what day the surgery is. And the most important thing is to get the knee straight after surgery so they don't get what's called an extension lag, because people want to make themselves feel better and they'll prop a pillow under their knee or they'll let it bend, and so they come in with it not straight. And that's the most important thing, is to get their quad firing and get their knee straight after surgery. So we try to get them in within 3 to 5 days.
So Dr. Metzler, this is a question for you. What are your thoughts on knee braces, and do they help prevent ACL injuries?
Good question. So there's not a lot of great data on ACL braces actually preventing ACL injuries. There is good data on ACL type braces preventing MCL injuries, which is why you see pretty much all the linemen in the NCAA and the NFL wearing some type of stabilization brace. If you can reduce the rate of MCLs, then hopefully in theory you could potentially reduce the rate of ACL injuries. And so it's not recommended for every athlete just to wear a brace to reduce an ACL injury, whether that be a basic hinge knee brace or knee sleeve or a functional ACL brace. Now, after surgery, it's a little controversial. I'm a huge fan of ACL functional braces. Some other surgeons aren't. The reason I'm a fan is because psychologically it allows an athlete to start to feel more comfortable returning to something, allowing them to increase their neuromuscular control, their proprioception, and feel more confident to gain muscle mass, to gain agility, to hopefully reduce their overall rate, not necessarily directly from the brace, but indirectly from the brace. And so I'm a big proponent of post-injury, post-ACL reconstruction, functional bracing.
Thank you. And Kathy, we have a question for you. Do you offer a strength training program for high school athletes?
So if I see it's from Catherine. It looks like her daughter was seen 8 weeks ago by a doctor. So if she has been seen by a doctor, then she could see me in physical therapy for what's called an evaluation and treatment. So if it was something that, or even, if she wanted to be seen for one session to get some strength training and to get started on a program, then I would do that. And then I could also help her get lined up for a strength training program somewhere if she wanted to continue that program in a facility, or if she just wanted to work on things at home, I can help direct that either way.
Awesome, thank you.
You're good. I'm reading the rest of, is this Catherine's question? It says she saw Dr. Metzler maybe.
Yeah, so Dr. Metzler she saw Dr. Metzler for a sprained ACL, and the knee seems to be healed, but it is not strong. Do either of you have any recommendations for that?
Well, if it's a full ACL, it's certainly very different. For a partial ACL injury, we do try to get it to heal up, which again aren't that common, but they have seen more recently over the past couple of years. A partial ACL injury that is with fibers intact, by 8 to 12 weeks, an athlete should be able to return to play if they have appropriate conditioning and strength. And so each knee is unique, and each knee has its own set of conditions that allow it to return to play. But if there's any question about confidence and muscle control and the ability to return to play and weakness, then certainly I agree with Kathy that should be evaluated and work with her, or she has great resources, and we have some good people that we work with. We can help get her set up with that too.
Definitely, and I think that going back to whatever the sport is for your daughter, you need to be able to see, can she go through the movements that are required for the sport, and can she do it safely with correct movement? So like I said, if she hasn't been seen by someone, you can do an evaluate and treat and kind of get everything in a visit or two.
Kathy and Dr. Metzler, it's Brad. A question real quick on that might be more topical given the current climate. As athletes or people in general sit and aren't active for an extended period of time, how important is making sure that you're looking at the dynamic warm-up and making sure you're prepared for any kind of intense activity or an increased rate of activity, given some of the injuries we've seen in pro sports after these long delays? And Dr. Metzler, is that even a factor, sitting for an extended period of time with little activity in these types of injuries?
Yeah, unfortunately, video games like Fortnite have really challenged us as parents, and amongst many other video games. But you're right, Brad. I mean, there's a lot that's unknown, but the reality is that 2 weekends ago there were 7 ACL tears in one weekend in the NFL, and that raised a lot of red flags. And there was no preseason. They probably only had 3.5 weeks before their first real game. I saw a huge surge in my personal practice. I did 6 ACLs this week, and that's scary numbers. I do about 150 ACLs a year, and I did 6 in 1 week, and that's a very high volume. And I think it's a testament to a lot of kids. They were homebound, and they didn't have a lot of options, didn't have a lot of opportunities to get out and be active. And we'll know more information, 6 months, a year down the road, like anything else. And maybe these injuries just would have been spread out over the course of the preseasons. But most of our soccer athletes got 2 weeks of practice before they played their first game here locally in this region. And so I think if we have to preach the data, and the data is going to suggest that inappropriate warm-ups, deconditioning that they underwent, thigh muscle deconditioning, core, hip, and quadricep strength deconditioning, has to relate to this increase in surge and lower extremity injuries. They're just ill-prepared for high-level cutting and pivoting. Athletes are athletes, but everyone's a little bit different. But unfortunately, I do have to believe that there's a significant impact of the COVID pandemic indirectly from a sedentary short period of their lifestyle that affected them.
Thank you for that answer. Kathy, I know you have a knee model at your disposal for those of us, and I know the internet's a great resource. Could you give a quick overview of, we hear ACL a lot. Can you kind of just show the audience who we have here, where the ACL is located and how it affects the knee real quick now that since you have that at your disposal?
So this is your patella, your kneecap, and your tendon. So I'm going to take it out when you look. So the ligament here that kind of crosses, this is a right knee, so it kind of crosses like your fingers like that. On the front, that's your ACL, and the one behind it is your PCL, and that helps keep this knee from sliding forward. And it usually tears in a rotational type of injury. So what happens is an athlete oftentimes will hear a pop as that ligament's tearing, and then they'll feel an instability. And what Dr. Metzler was saying about like the reason that you want to have them protected is it can tear the meniscus, which are these round little cartilage rings. And if that happens, that increases your risk of arthritis down the road.
Thank you. Viewer question here from a skier in their 60s who had ACL reconstruction a year and a half ago, feels fully recovered, and we collectively, the three of us, know that as we build our ACL injury prevention program, a lot of that we tended to focus on young athletes. For somebody in their 60s that's a skier, or even slightly younger or varied age, not necessarily high school athlete, are these types of exercises and programs helpful for multiple age brackets?
I can answer that one. I think that depending on your level of activity, if you're a skier, then obviously you want to be doing some kind of hip and core strengthening. So, you know, squats, lunges, lateral lunges, as long as you don't have a lot of what's called patellofemoral issues, you can get some of the softening under your kneecap. And I tend to see that with some of my middle-aged and older ACL patients, but if you can do those exercises and they're not painful, then I absolutely think you can do those. And if you're skiing, what are they called, mongrels, where you have to like bounce around, then you need to be doing higher level stuff. But you know, squats, lateral lunges, and definitely I would highly recommend, if you're not already doing some balance exercises, like on the BOSU or on a balance pad for your hips and your hamstrings. So all of that would be great to do. So I do think those would be good to do. You know, if you're not doing the higher level activities like running and cutting, you might focus your program a little bit differently than the higher level neuromuscular things.
Thank you.
Yeah, I'm sorry. I would agree with that. I think as we age, we need to stretch more, and we need to do a lot of lower impact activities. But low level plyometric training is excellent, especially unfortunately as we get older and potentially develop osteoporosis or osteopenia. We want to make sure we're doing some resistance training. So lower level impact stretching daily, core, hip, and quadriceps strengthening is going to be valuable for anybody, but particularly if you're going to go skiing, because we know that it's going to reduce your rate of re-injury and reduce the rate of injury to the contralateral side.
Just a reminder, if anyone has a few more questions that they would like to ask Kathy or Dr. Metzler, please submit them in the Q&A bubble on your control panel. And I think Brad only has a couple more. We have another question from a viewer. After release to return to play, how as a coach should you address the psychology of not trusting the repair?
So what I do is I talk to my athletes, I talk to each one of my patients about what they're afraid of. And the research says for you to actually address this directly with the athlete. What are you afraid of? What do you think is going to happen? How do you feel like we can improve your ability to to get through this. So, you know, what are you afraid of? And, you know, a lot of my athletes last year, they were afraid that they weren't going to get their starting position back, or their friends were going to be ahead of them. And of course, with COVID, half of them didn't get set back at all because no one was doing anything for this past year. But that's usually the question I get is, you know, am I going to lose my starting position, or am I going to be as good as I was before? So I kind of start with that angle. And then, you know, first of all, they have to address, with me, do they have any pain? Do they have good range of motion and good strength? Because once they get that, then I tell them that our job together is to work back toward what their 100% functional level is. And most of them do very well and are able to work through it emotionally. And there's different resources that we have. There's different sports psychologists that people can talk to if they even need that. But mostly, you know, being open, having an open dialogue with the coaches, with the athletic trainer, and with the athlete, with the parents, and making sure that everybody understands that this is a hard injury for an athlete or a person to go through, because they are missing out on everything. You know, making sure if you're a coach, you include them in the team activities, and you take them to the pregame meals, and you treat them just like they're part of the team. Because I think from an isolation standpoint, that can be very hard on them emotionally if they don't feel like they're included. So, you know, let them go to practices, let them be involved. I think that's going to be excellent for them from a psychological standpoint.
That's certainly my job as a physician, is to make sure they're safe. So I have to make sure that after the reconstruction, 9-12 months down the road, I rely very much on my physical therapist, like Kathy, extensively. We have a wonderful relationship. We probably rehabbed a couple hundred ACLs together, and work very closely. So when she gives me a message and says there's a concern or there's questions, I very much take that seriously. But that has to be translated over to the patient. But, you know, in general, from my standpoint, they need to have pretty much normal range of motion. They need to have near normal strength. And on physical exam, their ACL needs to feel firm and solid. And then I can give them the confidence that says, hey, your knee is stable, and now you need to be psychologically prepared for your turn to play. And that's something hard to address on a physician level. I heavily rely on, honestly, you know, physical therapists like Kathy, who have extensive experience, particularly in female young athletes, to help them guide them through that process. And I think that she probably has her own PhD in psychology after dealing with this. And we have talked about this before, but it's a significant challenge. Expectations, you know, they're hard to live up to for some of these young athletes. And there's a lot of scholarship expectations, and potentially beyond that expectations, that this injury takes a huge setback for them, and becomes, again, psychologically challenging. And I agree with everything Kathy said as a coach. As a coach, you please include them in everything that you would normally include, as long as it's a safe exercise or activity. And then understand that they're not going to be the same athlete maybe they were the first season back, or the first few months back, because they're not going to trust their knee to the same level they did before. They're not going to have maybe that same pep or step. But if you look at the NFL, and the numbers out of the NFL, for example, show that it takes 2 years for an athlete to even come close to their previous numbers. We have examples of Giovanni Bernard and Geno Atkins. We can look at those guys locally here and look at their numbers in production. We have to kind of, you know, almost understand that that same thing is going to happen in a young athlete. And so just being mindful of that. And maybe they were a U30 soccer player before this injury, and we hope we can get there. But maybe it takes us a while to get there. But understand that they'll probably get there. It just may take a while. And the psychology behind that for both the coach, the parents, and most importantly, that athlete can be very confusing and very daunting for them to overcome that psychological distress. And so, again, that's one of the reasons we're here to have a discussion. If we can prevent it, we don't hopefully have to deal with it.
One of the other things I was thinking, you might want to talk to them about goals. Like, what are your goals for, you know, short-term goals? You're obviously not going to be returning to play for 9 to 12 months, but what can you do this week? So I'll say, okay, next time I see you, I want you to be able to do, you know, 3 sets of 10 straight leg raises without a lag. And then 2 weeks from now, I need you to be able to do, you know, 2 sets of 10 ball squats. So just giving them some goals. And then, you know, from a basketball, let's just say basketball standpoint, if they can shoot free throws, they're not allowed to jump, they're not allowed to cut or pivot, but maybe they shoot free throws with everybody, or they line up and and cheer on their teammates. So anything you can do to get them included in what's going on at practice, I think would be a great idea from a psychological standpoint.
I'm going to make a final call here for questions, but as we wrap up here, Kathy and Dr. Metzler, you both have just talked about your extensive experience in this area with ACL injuries and the amount of time you guys have worked together. Love to hear from both of you. If you could offer one tip about either preventing an ACL injury, dealing with a post-op situation with an ACL reconstruction, or going through the rehabilitation process to get back to whatever level of activity someone wants. I'd love to hear each of you guys talk about one tip, one thing piece of advice you want to impart on somebody or a family or an athlete dealing with this injury.
I'll start here. I mean, I think for me, I'm unfortunately in a situation where most of the time I see an athlete, they're seeing me as, quote, the expert. I've done 700 plus ACLs in my career. I've been at OrthoCincy for 8 years. And, you know, by the time they get to me, they've already had an ACL injury. And so my charge to them is, look, unfortunately, the cards have been dealt. These cards stink. Nobody wants their child to have an ACL injury. I have 3 children myself. It's the last thing I ever want them to go through. It is a huge deal. Everything we've talked about tonight, it all plays a role. After we do that surgery, you know, and I do my part, you got to get off to a good start. You got to get off to a good start. That's my tip. The first month is just crucial. Getting normal motion to near normal motion, getting the swelling down, listening to your therapist, getting in therapy within 3 days, starting your home exercise within 2 days. You know, every day is a new day, and every day you got to get better. It is such a negative injury once an ACL injury is diagnosed, particularly an athlete, that we have to take the negative vibe from this, and we got to turn it over and make it to the best positive thing we can. And that's the only way you can deal with such a negative thing like this. If you maintain a negative attitude the whole time, then it's much less likely 9 months down the road that you're going to be ready to go, relative to saying, I have this injury, this stinks, this is unfair. We all get upset about it together, and then we take that negative energy, we turn it to positive energy, and from day one, post-op day one, we go, and we've got to grind it out, and we expect you to do your part. I have to do my part. The therapist does their part. And if everyone does their part, most athletes are able to return to play. But that's my biggest tip. I know it's a big tip, but get involved with it right away post-injury. If it's pre-surgery, you're doing rehab right before you even have surgery, right after surgery, and stay engaged the whole time. And like I said, if everyone does their part, most people will return to play.
My area I think I want to talk about is if it's pre-injury. So say you're a family or a coach or someone who hasn't been through this, what can you do for your athletes? And one of the exercise physiologists that taught a seminar for us probably 15 years ago, he said that the speed skater exercise was the #1 predictor of athletic ability. And so I've kind of been focused on the way that kids move for my whole career, and I watch that movement in kids, and I want it fixed. So if you're a coach or a physical education teacher, if you're a parent, have your kids work, even if it's a side step and hold, like a slow controlled side step and hold, watching the alignment, just watching the body coordination. That's kind of one that you can really focus on, even at home in the kitchen. You know, I kind of, okay, talking to my kids, okay, let's do a little side step and hold while you're telling me about your day. I know it sounds ridiculous, but I don't want you getting hurt. So we're going to do this while we're talking in the kitchen. And then we kind of have contests with, I have older kids and younger kids, you know, and if I have, like my earlier patient today, my cheerleader, okay, we're going to do this move and you're going to get good at it because I don't want you back in my clinic anytime soon. So that's one of my like pearls for kids to do, for even the 60-year-old skier. Do the side step and hold. If you're strong enough, do a side hop and hold. If that's easy, do a side hop and hold onto a Bosu. Just changing up that angle and watching your hip and knee alignment, and then really kind of focusing on the technique would be a good like pearl to work on between, you know, now and forever.
Thank you both. I think that'll wrap up our questions. If anyone has any additional questions, please feel free to pop them in the Q&A area. I just want to remind everyone to please check back to stelizabeth.com as we will be launching an in-depth ACL injury prevention program later this fall. So your feedback is very important to us, so please take a moment to fill out the survey that will appear when you exit the webinar. If you don't have time right now, we'll be sending follow-up emails via Zoom that will include another link to the survey, and we would love to hear your feedback about the platform and the presentation. If you would like to refer back to this presentation at a later date, please visit stelizabeth.com/livingwithoutlimits, and this webinar has been recorded and will live there in the next 24 hours, so please check back. Any information or questions, please visit stelizabeth.com/ortho, and you should be able to connect anywhere that you need for information there. I'd like to thank everyone again for joining us tonight, and have a great rest of your week.